Welcome to All Systems Ergo, a human factors and ergonomics podcast delving into the fascinating world of healthcare. My name is Fran Ives and I am a chartered human factors specialist. I'm naturally curious about people, and throughout this series I want to explore different areas of healthcare human factors and the people who work in this diverse discipline. Hello everyone and welcome to episode 1 of All Systems Ergo. I wanted to record a podcast series because I was really keen to explore different areas of healthcare human factors. And over the past few years, many of us have attended numerous webinars and I wanted to do something a little bit different. I really enjoy a good conversation and thought this would be an ideal way to delve into different areas of human factors. Now, it might seem a little odd that my first guest is based in aviation and not healthcare, but stick with me on this one as I hope you'll find the conversation today a really honest and insightful one. Enjoy. So hello and welcome to this episode of All Systems Ergo. So I've made the decision today to start off this Human Factors in Healthcare series by talking to somebody who spent the majority of their career in the transportation industry. So Steve Shorrock is my guest today, a chartered psychologist and chartered ergonomics and HF specialist who describes himself as an interdisciplinary humanistic systems and design practitioner. Steve has long been interested in and a champion of healthcare human factors. So I really wanted to talk to him today about why it's important to integrate human factors into healthcare and what we can learn from his transportation experience. So thank you for joining me today, Steve, and welcome.
Thanks, Fran. It's a real pleasure and privilege to be your first guest, so thanks for inviting me.
Fabulous. So there are lots of things we can talk about and lots of ways we can start off, but the question I want to start this episode off with is, you bring 25 years of human factors experience to this conversation and a wealth of aviation knowledge in particular. But what is it about healthcare that leads you to promote and champion better human factors integration?
Gosh, that's a really good question, and it's quite a big question. I think I could first just see the disparity between healthcare and, for instance, transportation. And I've worked primarily in aviation and air traffic control in particular, and also in rail. And I could see the disparity in integration. When you look at, for instance, my old employer was NATS in the UK, which is the main provider of en route air traffic management services and also quite a lot of airports, the major airports really. And in a place like NATS, you've got around 30 qualified and experienced human factors professionals, which include classical ergonomists and organizational occupational psychologists, and a bunch of people together are human factors specialists. So when I look at that, it's been around 30 people for quite a few years. And then I look at the NHS, which is a vastly bigger employer, around 1.5 million, maybe 1.25 million full-time equivalent staff. And if we count the number of similarly qualified full-time equivalent people in the NHS, it's no more than around 10 directly employed from what I know of. And that's for over 1 million employees. NATS is a company of around 4,500 employees and around 30 specialists. That to me just never added up, and I couldn't get over that statistic. It's the same when you look at the RSSB, the Railway Standards Safety Standards Board, Network Rail, British Aerospace, defence organisations like Kinetic. You go to any of those big organisations and you'll find that. So there's this big disparity. So that's kind of one reason. Another reason is much more personal, and I'm not quite sure how it influenced it, but a long time ago now, like in 1993, my mother died of cancer. And what happened was she had an operation, breast surgery operation, and then afterwards, she went to have some cancer treatment, and she got to the oncologist, and the oncologist said, "Well, when you've had your surgery, this is what's going to happen." And my mum said, "What do you mean? I've already had it. I had it weeks ago." And basically, that letter had never been sent, and that time was kind of lost, and it was, I don't know, a few weeks. And so you just look back and you think, what would have happened? That very small, tiny thing about sending a letter that somehow got missed, So yeah, there were things like that in my in my history, being a patient and being a family of a patient, as well. But primarily, I think it's just healthcare. Something I feel really. I hate that word passionate, but I just think it's really, really, really important. And it's the most important sector to get right from a human factors and safety point of view. And it's the least well-served sector. And that just doesn't add up.
And you talked about, that personal experience, but also this just doesn't add up. You've given examples of other industries that have got much more established and larger groups of HF specialists. So what is it about those industries that is different to healthcare? Why have those industries got those established teams and we in healthcare haven't?
I think there's a few reasons, Fran, for that. One of them is that they are highly regulated industries for a reason, and they're regulated in a much more sensible and straightforward way, with fewer regulatory bodies with much more power. The HSE, for instance, has huge power, equivalent to the police in some areas. It also has, and always has had, good capability in human factors. So a book that I edited with my friend Claire Williams, also a human factors specialist, we a few years ago, 4 years ago, I think it was released, something like that. And there's a chapter there by John Wilkinson, who was a very experienced regulator, great chap. And he wrote a really lovely personal account of being a regulator, setting up a team and of human factors specialists and so on. And that's really missing in healthcare. So there are pockets of specialists like where you are. You're like one of these golden examples of very few precious rare resources. But when you look at the top, there's nothing. So that I think is one reason. It's the structure of regulation in high risk industries, the competency of regulators, and how they are set up, and therefore what they require of those being regulated. The other issue that's obviously related to that, that's been said before, is that when people die in transportation accidents, in energy related accidents, and so on, they tend not to die one at a time, sometimes over long periods. Many people die, and so it's very visible. It's very visible to the media, therefore it's very visible to the public, therefore it's very visible to the government, and therefore, again, going back to regulation. So it's just one of these things. The most similar is probably, in some ways, is probably road transport, because again, people tend to die in ones, twos, or the worst case, small numbers, but frequently. And therefore, some things just don't get the attention that they should do. So the paradox is the safest industries are the best served by human factors.
That's really interesting that people die in healthcare all the time for a multitude of reasons, but we accept that because we don't hear about it. There's an acceptance that people will die, they're going to hospital, and some people will be successfully treated and come home, and some people won't. But we don't always, as the public, look into or hear about why some of those people who've died have died in the same way that we would if there was a plane crash or a train crash. The media will really bring that to our attention and really look at the numbers and who those people were. And it's very much then in the public's forefront. We don't hear about it, do we, in healthcare?
Not so much. I mean, you have major systemic problems that come to light, like mid-staffs, for instance, like abject failures in social care. One thing may be that typically there are many people obviously involved in these stories, and so somehow it's just a big mess that's quite difficult to sort out. And there's contributing factors obviously going all the way from the government level, for instance, performance targets for accident emergency, through to frontline levels, such as how does somebody make these trade-offs when it comes to admission in terms of meeting targets, which now that's a totally different story. But for mid-staffs, that was quite relevant, for instance. So it comes to light in those major ones. It comes to light in smaller, well, I shouldn't say smaller, but individual cases of harm. But there's many people involved, and that's perhaps another aspect of the mess. And in aviation, as an example, it may be that there's a manufacturer that's primarily involved, such as Boeing's been involved in some cases. It may be that there's an airline that's kind of involved. In some cases, there can be whole cultural issues in terms of, for instance, pilot behaviours, but typically it's more restricted than it is in healthcare, where the harm has tentacles which reach out all the way backwards and forwards and outwards in all different directions.
And you've sort of touched upon there just sort of how complex and how broad human factors is. I think all understand that healthcare is a huge area. It's very complicated. Things are changing all of the time, and our staff are under huge amounts of pressure, particularly at the moment. What's the area of human factors and or healthcare where you think we can actually make the biggest difference?
I guess it's worth looking at what the systemic levers are. So you'd have to take a step back and say, well, if you were to work on one lever, which would have the most widespread influence, and something for me, they would be around workforce issues. They would be around issues of retention, how you actually treat the workforce. Healthcare is one of these classic degraded systems, as all systems are, because they're not as they were designed, they're not as they were intended, and so on, and they degrade over time. But healthcare has another unique element that I think it can be quite a degrading system. And so these problems with retention are enormous. Where you have staffing, workforce problems, this should be one of the first things that you're kind of looking at, I think, because that's relevant to everything then. If you want to have patient safety specialists working, well, you need the staff. If you want, if you want to have people reviewing the policies to rationalize the procedures, the forms, the paperwork, well, you need people to do it. So you need people to do all of these things. And if everyone's really stressed out, rushed off their feet, they've got no spare capacity, there's no margin, then that's a huge problem. So how we can work in those kind of areas, that's quite a major lever. I think there are others, such as how people are treated after incidents. Some of these really go outside of human factors in a way, but on the how we say sorry. So there's lots of big issues like that we can work on, but then there's lots of kind of smaller issues as well. But in terms of influence across the entire NHS, I'd probably be looking for those major levers, which means that again you need people closer to the top, giving advice on some of those kinds of things.
And if we nailed it, if we valued human factors in healthcare in the same way as we do within nuclear, within transportation, what would it look like? What would that really good application of HF look like?
In terms of the outcome for people, I mean, people should enjoy coming to work. They should feel valued at work. They should feel safe at work, both psychologically and also physically. They should not be completely worn out, stressed out by issues that we shouldn't even be arguing about, like parking, for instance. Like all of these, what Herzberg called hygiene factors. These kinds of things have to be really sorted out before we start talking about well-being programs and so on, because there's a real fundamental disconnect there. But I think there would just be joy in work. There would be connection. Things wouldn't feel as hard as they are, and the day wouldn't feel as long as it is. So that's a kind of feeling approach, I suppose.
So if someone's listening to this podcast who's working in healthcare and thinking, right, we need to integrate HF better, or even just start thinking about human factors better in my organisation, can feel incredibly overwhelming and really quite confusing as to where to start. What would your advice to those people be, if they want to take some action? Where would they go? What would they do?
It depends what they want to do, really. I think there's two different approaches. So one is, well, do you want to integrate human factors into your and your team's work? So that's one question. As a clinician of any kind, or do you want to become a human factors practitioner? They're two different sort of routes. But in either way case, you've got to start by being curious and being curious about people's work, especially other people's work. So who are the people that you interact with? Who are the people who you should interact with? What is it about your work that others outside of your profession might find surprising, but that is interesting or relevant to them, and vice versa? What is it about others people's that work that is relevant to you and you really should know about? Most improvement opportunities are in the boundaries between professions, between units, departments, locations, both hierarchically, horizontally, and that's the time. That's where we should be spending time, looking at being on the edge of our professions, being on the edge of our units, really trying to make those connections. Typically, what I find certainly in my industry is the problems are not really inside the profession as such. It's usually the boundaries. It might be, for instance, the boundaries between air traffic controllers and procedure writers, for instance. So it's almost always in the relationship. So no matter how technical, no matter how scientific, no matter how clinically complicated, all or almost all opportunities for improvement, or at least most of them, are actually in those relationships. That's the conduit, that we should be focusing on. So yeah, the connections, that's human factors, isn't it? It's about the interconnections, the interrelationships. That's what we should be focusing on.
And it's really interesting what you said about being curious about people and being curious about their work, and I often think that about my own job. To be a human factors specialist, you have to have that curiosity, that sort of desire to understand a little bit more about those people doing that job. And I spent a number of years working as a human factors specialist in a large NHS trust, and I often used to reflect on what a privileged job that was, because I had the ability to pretty much go everywhere. I sort of felt like I had an all access access pass. One day I could be in mortuary, the next day I could be watching someone's neurosurgery, and then up to oncology. And what a privileged position that is to be in, to be able to go and talk to staff, to go and watch what they're doing, ask them what they're doing, how they're doing it, and how they feel doing that. And it really struck me that many of the people in the trust would just come to work, do a really fantastic job, but not necessarily really go beyond their unit, their department, or their ward, and wouldn't necessarily have an appreciation of what people were doing in other parts of the trust and how that maybe influenced what they were doing or impacted what they were doing. And I sort of feel that I had the time, it was my job to go and seek that information and to sort of, satisfy my curiosity, if you like. But not everyone gets to do that. So that really, really resonated with me. But in looking at work and understanding people working is something that you talk about quite a lot. And I also talk about in my human factors work, the varieties of human factors work, the varieties of human work. For those listeners who are unfamiliar with the varieties of work, are you able to explain a little bit about what they are, but also why they're really important to us as human factors specialists?
Yeah. So there was a distinction drawn, I think, first by Eric Hollnagel. I'm not sure who used this exact term, I should know, but of work as imagined and work as done. And that term was certainly used in a white paper that Eric, myself, and two other co-authors wrote on, called Safety 1 to Safety 2 in 2013. And that was the first white paper on that topic. And what was talked about there was work as imagined being basically what people think that you do, what we think that other people do, and work as done being what actually happens, actual activity. So I extended that in a way to think, well, work as imagined could also be about, well, what we imagine we do, which isn't necessarily what we do. If you were to see a video recording of yourself driving, for instance, not you personally, and what we think will happen in the future, so going from future to projection, and what we think happened in the past, of course, when there's been an incident, when we don't have perfect recollection of that, and what we think we would do in a particular situation. Oh, I wouldn't have done that. I wouldn't have behaved like that surgeon. I wouldn't have behaved like that anaesthetist on this. So they're that kind of two. But then there's others. Going back to French ergonomics in the 1950s, they talked about le travail prescrit, or prescribed work. So that was the kind of obvious work as prescribed, which is the policy, the rules, the guidelines, the regulation, the laws in some cases, the checklists, like the World Health Organization checklist. And then you have, and then I thought, well, but then there's what people say about their work, because as Margaret Mead, the anthropologist, was credited with saying, she didn't actually, but there's what people do, there's what people say, and there's what people say that they do, and they're different things. So that's the work as disclosed in verbal or written form, So if you have to complete some kind of report on an incident, what are you going to write on that? That will be driven at least partly by fear of consequences, for instance, and what you can remember. So those were the main four types. And then I started to think about, well, there's all sorts of proxies, like work as analysed when we do investigations and task analysis, job descriptions, job analysis, work as simulated, work as observed when we observe people at work, work as judged, and so on. So there's this work as X, basically, and you could add all sorts of those, but I find it useful to look at those as an alternative to saying either people are doing things correctly according to the book or failing. Which was kind of a old binary of, human error versus correct performance, let's say.
Because everyday work is really messy, isn't it? You know, you can have these beautifully written procedures, but we all know in healthcare, you know, maybe that piece of equipment isn't working today. Maybe it's being used by somebody else. Maybe we're short staffed, you know, and the reality of work can change daily, hourly even. And I think we all know that, but to actually really think about what the different varieties of work are can really help us to sort of think, of course, yeah, what people think we do is potentially quite different to what's written down in those procedures, is quite different to what I say to somebody I do or what I actually do. I certainly find it really useful to keep coming back to those varieties of work when I'm doing my human factors work. How do people really understand what happened? You know, how do we know which snippets, which bits of each of those varieties to pull out to build up an accurate picture of what's going on?
It's a great question, and that really is part of. We're going really into craft now, and it probably makes sense to start with the conviction that you'll never understand work. Work is real human work is ephemeral. It's unknowable, and it's not understandable in any complete sense. And at least part of that is because for a lot of work at least in healthcare, a lot of that work is going on in the head. And even the person themselves is not that aware of it because so much of it is unconscious. What you can do is approach an understanding of it, accepting that you'll never really understand it. So that's the kind of humility piece that, you know, to start with. That already is useful in giving you information that you'll never really truly understand everything. So that's useful, because if you're going to form a judgment based on what you find out through these, what I call proxies for human work, then you're going to have to add in a large margin of uncertainty. Typically, I guess if you approach it like a social scientist, then how are you going to find out about what is essentially a social interpersonal activity as well as an individual cognitive activity? And you're going to have to combine these and get multiple perspectives on each. So, for instance, if you're going to do some work as disclosed, you're going to get some descriptions of work. You probably need to get more than one. You know, you're probably going to need to ask a few people. For example, you might have an incident, and so you interview the person who was directly involved. Well, what does that tell you? Well, it tells you what they can remember and what they're willing to tell you about a particular event. You might get the impression that it was completely unusual, and that person might start by saying, oh, it was all my fault, I just completely messed up, I forgot. Quite common that professionals do that. Or they might not want to talk at all. You might talk to a few more people and find out actually there was nothing that unusual about what was going on here. This was really more or less how things go. But on this occasion, the stars aligned in all the wrong ways and things went wrong. So you might do a bunch of kind of interviews with different people in different kinds of roles, some who might be a bit more blunt end, a bit sharp end, and so on. But then you're finding out one aspect, which is what people are willing to say to you and how much they know, can remember, and how honest they're willing to be with you, depending on your role. But then you might say, well, actually, there's a difference between what people say and sometimes what people do. So maybe we can observe, shadow people, you know, at work. I mean, they're the main two things that you can do, right? I mean, there's two methods. You listen to people and you observe people, and then everything else is kind of building on that. So yeah, that's part of the craft, really, and that takes that actually takes quite some training to learn how to listen to somebody's account, how to ask the right questions, how to observe, and also who observes. What's your role? How are you perceived? Because that will affect how people behave and what people say.
Absolutely, and that really resonates with me, thinking back to my own experience of being a human factors specialist and going to all sorts of areas of the hospital to observe. And, you know, I often say to people that the most valuable tools I have are my eyes and my ears. But you have to be really able to tune in to the environment and the situation that you're in, and really sort of understand, what do people feel here about the presence of somebody they don't really know? Because actually, you know, to have me walking in, somebody they don't know, can really change sort of how they are, how they work, what they do. You know, and I had to become really quite good at sort of building relationships with people and allaying any concerns and fears they have, and really trying to gain that trust very, very quickly. And that would be with people of all grades, all different specialities. You know, and you really had to be quite adaptable in your approach. That was one of the elements that I always really enjoyed, because I find people so interesting. I really want to find out about them. It can be an incredibly daunting thing to do. I mean, I remember being a relatively new graduate going into all sorts of areas of the hospital, not understanding the clinical elements at all, and actually feeling really quite out of my depth. But one of the things I also learned very quickly was that, because I'm not from a clinical background, it was okay for me to ask the seemingly dumb questions. You know, so tell me about this. You know, I've not seen this, but can you explain? And actually, you can turn that around to be a real advantage, because people often like to share their knowledge. They like to feel like they're teaching and they're telling you something. So that's something I often say to people who are starting out, is don't be afraid if you don't understand the clinical procedures that are going on, and don't be afraid to ask questions. Is that something that you feel, you know, is useful and applicable in all areas of all different industries in terms of human factors?
Yeah, I think in healthcare, my experience as an outsider is that people are remarkably willing to give of their time to kind of explain, you know, how things work. And as you just said, Fran, people are more than happy to talk about their work. They'll spend all day talking about that. And that's why talking about just day-to-day kind of activity, which is something we don't do a lot of, is such a great thing to do, rather than focusing always on failure, where you've immediately got a fear barrier up. So yeah, we can ask, not only do we have a license to ask questions that seem fundamental, but we will ask them because we're not encumbered by all sorts of assumptions. So, for instance, it's a great benefit if you're a nurse or an anaesthetist or whatever kind of specialist you are, to have all of that background knowledge. But the flip side to that is there's all sorts of questions now that you won't ask, because you'll tend to make assumptions that elsewhere it works in the way that you work or that you're familiar with. And so, like my daughter, for instance, she's autistic, and she has a way of asking questions that really just like flip me and think, like, wow, I've never even thought about that before. That's a question I've not even thought about asking. And it's that kind of thing, actually. It's to take away all of the assumptions, to say, well, actually, why do you do things in the way that you do them, or why do you do that? So yeah, it's a useful thing to have, and it shouldn't put anybody off.
Mm. And of course, in healthcare, you know, we have huge working populations, and neurodiversity, as you sort of just touched upon there with your daughter, is something that we absolutely need to be aware of when we're thinking about how people work, how they work differently, and why they might possibly work differently. Is this something that we give enough thought to in human factors, do you think?
I don't really see it. I don't really see it mentioned anywhere. I'm not really across, you know, the research on it in human factors, if there is any. But I mean, if you look at the data that we have, I'm not sure that it does really cater for that, and I'm not sure we probably have that good an understanding of what neurodiversity neurodivergence really means. But I mean, from a personal perspective, I'm from a whole family of neurodivergent people, and so I find that kind of interesting in just a different angle, a different angle on the world. Yeah.
So what is it about healthcare, that drives you to keep championing and keep sort of prodding that stick, if you like, in terms of trying to support the people who are sort of, working in human factors, but also trying to raise the profile and help people recognise the benefit? What keeps that drive going?
There's the factors I mentioned initially, and it just still bugs me. And so I'm never going to stop poking that stick. It just still bugs me. There's another thing, I think. There's just sort of a sense of obligation of not in a bad way, but that it's important. And I think the NHS in particular, in the UK, it's really, really important. Health and social care is really, really important. We all need it. It's not something you can live without. And through having kids and kind of old members of the family being in hospital and so on, you just see how how much my life would have been different. I mean, I've got one daughter, for instance, that she's got a single kidney, for instance, and there's been a few complications around the way that all of her insides are arranged, that required surgery once, and it's just like she definitely wouldn't be here without that surgery. And so it's like, this isn't like, okay, we could or could not get an aeroplane or a train. This is, you just simply wouldn't be alive. Similar to me, I had emergency appendectomy when I was about 16, and it was very close to bursting, so I would have got septicemia. And it's just like a little thing you take for granted. Oh yeah, you have your appendix out, but actually, no. If that hadn't have happened, I wouldn't be here to talk about it. So I'm just very, very aware of that. I'm also aware that it's, as I said earlier, it's a sector where people are absolutely worn out, fed up. Leaving in many cases because they can get paid better or they get better conditions elsewhere. I mean, these so-called hygiene factors shouldn't be an issue, and so we need people to speak up for humanistic work, for decent working environments, and these kind of basic things. I also find that people in healthcare are very, very charitable in their time. They tend to be very interested in human factors because it's obviously directly relevant to them all the time. They're not sitting in a nicely designed air traffic control tower or radar unit where, the displays, the font sizes, everything, has been usually designed quite carefully. They've got a bunch of equipment. They turn to work. They don't know necessarily what kind of equipment they're going to face, because there's so much variety. They don't, there's so much variability there in the environment that, I think we should just all be getting behind supporting people who work in this environment. So, sorry, that's the long answer.
And one of the things I've noted from our conversation is that you've really taken the time to share a number of personal stories, which has helped to, I suppose, demonstrate your own passion and your own reasons for taking the time to champion human factors in healthcare. Sometimes it can be really hard for people to actually sort of speak up and share those personal stories. So how can we encourage more sharing by staff and remove that fear element of being blamed?
Yeah, it's a really tricky one, because you brought in the element of blame there, so that indicates that they've done something wrong. I think the one difficulty is we fear talking about just even, let's say, ordinary work, because it is messy, and we fear that people won't understand that. They fear that they won't understand the goal conflicts that we face between various different goals. And there is no safety first. That just doesn't exist. There is no zero harm. That doesn't exist, never will exist. There's just a bunch of trade-offs by virtue of being in a system which is under-resourced, very, very complex, and very compromised. What does it take for us to be honest? For people in healthcare in particular, we're talking about to be honest. That's the question. What does it take to be honest? And the difficulty is, it's not just talking to your managers, and it's talking essentially to the public as well, potentially revealing things to regulators, the criminal justice system. So that's really, really complicated. And also to your own team, who we tend to fear most, the person that we work with most directly, even though we don't talk about that because it's a taboo, but we fear their judgment because we do not want to be expelled from the team, from the clan. And so we know what we can and can't talk about. But perhaps if we get multiple different people talking about a situation, change some of the language as well to get rid of the more negatively loaded ones. I've tried to encourage using more neutral language, so talking about things like trade-offs. So you talk about trade-offs, well, immediately now you can see that we've got two competing things, or you talk about dilemmas, different competing goals. So yeah, I'm not sure how you do that. It does also take a bit of courage, to speak out about your own story. I spoke out about having PTSD, which I've had for like a long time, since being certainly like a teenager. Wasn't really related to work. But I'm aware through doing that lots of people in healthcare do have either diagnosed or mostly undiagnosed PTSD through the situations that they're encountering. So I spoke out about that, for instance, or told the story, and it is quite kind of scary because people have a particular perception of you. You're a doctor, you're a surgeon, you're a nurse, whatever, and then you disclose this thing, whatever it is, depression, anxiety, PTSD, complex PTSD in my case, and it's like, that changes somehow. Now, it doesn't change your capability, your competency. It doesn't change any of that, actually. It's just another bit of information that changes the story. But what I've always found is that the reaction has always been positive, encouraging, and other people have opened up in a similar way by modeling that kind of openness. Look, this is nothing kind of weird. It's something that happened. My brain's been forcibly made, neurodivergent. And I live with it, and actually things are getting better when I do these things, and there's a message of kind of hope in there. So when you take that step, actually, you find that the reaction is typically good and helps other people. So it does take a little bit of courage, and you have to know a little bit about the boundaries of what's going to be a safe thing to talk about in a safe environment. But there is never kind of, let's say, complete psychological safety, is there? There is always a little bit of risk when you disclose something.
It's interesting you mentioned psychological safety. It's something that I talk a lot about at work and in human factors. So that's one of the things that, if I'm with somebody and I want to understand what they're doing, it's more than just watching how they're working. It's really understanding them and knowing that, how they're working and what they're doing can be influenced by a multitude of things. It can be influenced by what else is going on with them, what other things they are dealing with. And that can be incredibly hard for some people to share. They don't always know what the consequences are. They don't know who you are. So actually sharing those elements of them, incredibly personal, is sometimes very hard. So it's really nice to hear that after you sharing your stories, you've actually felt very positive in terms of the response to that.
Yeah, and I think most people feel the same, about that. But that's a great thing that you've done and that you've talked about throughout. Meeting so many different people from so many different roles, and what you said there is quite true. That it all starts with the relationship. That's really the most important thing, to invest in diverse relationships. Who is it that you don't hang out with? And I always say, if you go into like a conference or something, just observe how people go in, and they all sit next to the person they know really well, which is the person they can learn the least from. So we're not naturally inclined to do that, but there are ways of doing it, of just creating an environment where people feel comfortable to interact with each other, to get rid of the hierarchies, to get rid of the discipline boundaries, and so on.
It's that role modeling, isn't it? If we see our leaders within our own organizations sharing information and providing that really good model for us to look up to, then my feeling, and I don't know what your thoughts are, is that if we see that, it instills that confidence that we can also do the same. Is that something you've ever experienced yourself or seen happening in the workplace?
Yeah, well, that role modeling is important for any kind of influence, but for me, it's just a way of being. Really, it's a way of just being authentic. Just be who you are, and just try and be a decent person, try and be a kind person, and try and be curious of how other people work, of what matters to them, what they enjoy about their work, what they're proud of, what they wish they'd have done earlier. Start with that stuff, and then start with what's strong, before, and then you can move on to talking about things like dilemmas and difficulties and what makes the day longer than it needs to be and harder than it needs to be. When you're having those conversations quite routinely, it's like, oh, okay, that's how we can talk about this kind of stuff, to model that curiosity and sort of relationship building.
Two good takeaways really there, being kind and being curious. And one of the things that I sort of quite like using curiosity for is to understand, that's gone really well. Tell me how you've done that. Or even if actually it's nothing particularly remarkable, but someone's just done something that has really impacted another patient or another member of staff. It's actually recognizing that and being curious to tell me about that, so that we can actually learn from that good stuff as well. It helps that individual understand that their work was valued, but that curiosity can be put to good use when you understand a little bit more about why that did go well. That sort of, learning from excellence, that learning from the stuff that's gone well.
Yeah, 100%.
One of the things I just wanted to finish on was an article that you wrote last year, reflecting on your 25 years in human factors and the sorts of things that you've learned and found to be most important in your practice and in the design of work and improvements of work. And you talk about things like nurturing relationships and considering all stakeholders, getting involved in projects early, really good practical sort of reflections. If you think back to those reflections, are there any that really stand out to you as being a bit of a golden nugget?
Well, I put the first one, the most important, for a reason. We've talked about it a lot already, and that is really the relationship aspect. I mean, that transcends pretty much everything else. But otherwise, I talk in that about transcending disciplinary boundaries and staying on the edges, and that's kind of all related. It goes back again to relationships, of not just being solely preoccupied with your own little profession or whatever, but really trying to stay on the edge, where you see further from the edge, between your profession and the other. So if you're a doctor, to try and stay on that edge, to collaborate with nursing professionals, for instance, or whatever specialty you're in, try to form links between hospitals. You mentioned there about good practice. People are always trying to say, oh, what can we learn from aviation? Well, actually, you could learn a whole lot more by what's going really well in other hospitals than you could from aviation. We don't really do that. Why not? We have excellence reporting schemes within hospitals, and whatever word you want to use for that. I mean, what about the good practice that's elsewhere that could be learned from, much more systemically. So yeah, it's all around those kind of boundary things, really. I'm trying to think of what else, but I talked there about thinking critically but not being dogmatic, as well. I think that's quite important because there is quite a lot of dogma, and so the ability to think critically about problems and situations and opportunities, but also take multiple perspectives, at the same time, seems to be something that's an important thing to do, and that's it's such a contentious environment that we're living in at the moment, with so many tribes and clans and different ways of thinking. And I'm more interested at the moment in, right, so when you come across people that have such a different way of thinking, which might not be very evidence-based or whatever, how can you engage with people like that without just getting angry and saying, well, the evidence doesn't support it, the numbers don't support, because that doesn't convince anyone. And so how can we actually find what we agree on first before we move on to other perspectives? And we need to work a lot more carefully on that, because I think we're all failing really bad. We just get really angry, and it's just like a really basic human emotion that comes up, and then that shuts down all discussion. And then then there's no relationship building to be had. So how can you be in relation with people and have conversations even when you have really different perspectives on problems and opportunities?
So it's really starting off with finding that common ground, building that solid foundation, and then going on to explore things that you maybe don't agree with. That's a really nice sound bit of advice to finish our conversation on. Thank you so much, Steve. I could keep chatting for a long time, but I'm aware that you've probably got 101 other things to do. So thank you so much for giving us your thoughts and your experience and your perspective on human factors in general, but also where it sits in healthcare and why it is so important. And thank you for championing it. And I'm glad to hear that you will still keep poking that stick. So thanks very much for your time, Steve.
Thanks, Fran. It's been a real pleasure to talk to you, and I want to find out more about your job. You've piqued my interest about all of this, all the stuff you do, and all of the Access All Areas Pass that you've got. We need basically a lot more Frans. So somehow you need to replicate yourself in all of the various different trusts that we've got, and not just once, but multiple times over. So that should be your next goal somehow.
Okay, I shall work on cloning myself.
Yeah.
Thanks, Steve.
Thanks, Fran.
I hope you enjoyed my conversation with Steve. He gave some really personal reasons for being passionate about healthcare human factors, despite working predominantly in aviation. Steve has got a really good blog called Humanistic Systems, and we'll put the link to the blog in the show notes so you can check out some of Steve's work if you're interested. Thanks for joining me today, and look out for our next episode, which will be coming shortly.